All right, so I'm going to cover at lightning speed the relationship between chronic pain and anxiety, and also fear. The difference between anxiety and fear will be one point of focus. So a little bit of brain mapping. This is the outside part of your brain. You'll probably recognize it, that sort of curly, packed together. It's wadded up like that with all those little curls so that more of it can be stuck inside a limited space, your skull. This is the outside. This is what we call the cortex. And we'll talk a little bit more about what each of these areas do in a second. This is on the inside. These are the limbic structures. And they, while the outside part does thinking, higher order stuff, analyzing, forming speech, learning, these inside parts drive the engine. They are where impulse lives. They are where our desires live. And it's going to become extremely relevant in just a second. So this is just another shot of the brain. The brain is oriented in a little bit different direction in that the nose is going in the opposite way with this picture. But in this picture, you can see these striations, this material that looks obviously like tracks or pathways. And that's what it is. These are called corona radiata, and they connect these internal engine driving impulse feeling parts of the brain with these outside parts of the brain that do the thinking and the analyzing and the remembering. So it really looks like what it does, it looks like that. That was a really inarticulate sense, but you know what I mean. So now, when we're exposed to any kind of emotional stimulus, and any strong emotional stimulus, maybe it's fear, maybe it's sexual arousal, maybe it's seeing somebody that we think is really hot, maybe it's seeing a delicious piece of chocolate cake on someone else's plate. It could be any strong, visceral sort of emotional stimulus. The brain can process it in one of two ways. There is the low road way, which I'll refer to as quick and dirty, and the high road way. Now, why do I call this low road quick and dirty? Because in the time that it takes for the stimulus to enter the brain and go to where it's processed on this low road is very, 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 very quick. Whereas if it travels this other way, up through that outside part of the brain, that curly part of the brain, it's slower. It's a much slower process. Now, the up road part, the high road part, is far more accurate because it involves analysis and attention and concentration and thinking about. But this low road part is not all that accurate. Its evolutionary purpose is just to move fast and get you away from something in the case of something dangerous or a fearful stimulus. So let me tell you a story that will bring all this home. And you're probably wondering, what does this have to do with pain? Or maybe you put it together already, but we're going there. So I had a friend, and she wore glasses, only this day she didn't have them on. And she was sitting on a bridge in Indiana and looking out, sort of musing about her life, I suppose. And she saw a stick next to her. And she reached over and she grabbed the stick, only to find out that it wasn't a stick at all, that it was a snake. And so she threw the snake into the water. Now, what does that have to do with any of this? So the difference between a stick and a snake, metaphorically, is very germane to your experience of facial pain. So I'm just going to read this out loud. The high road and the low road paths do not necessarily reach the same conclusion. I mean, if she would have been using the high road path, she would have been able to ascertain with thought and analysis, that's a snake, it's moving, sticks don't move. But she grabbed the stick and it moved instantly, which created this fear stimulus and caused this low road phenomenon to occur. And what the point of all of this being is that the high road is going to process things in a way that is much more accurate, but at the expense of time. So to take it to you, to make it relevant to your experience. When you have an experience of facial pain, it initiates a low road response. It causes you to look into your environment for the provocative stimulus, the dangerous thing, and identify it, but not in a way that is likely to be factually accurate. It's likely instead to be full of factual inaccuracies. And this becomes extremely important in the way you conduct your lives. So evolutionarily speaking, in terms of how we evolve these big brains, it makes sense for the faster pathway to err on the side of caution. It's probably better to treat a stick as a snake than a snake as a stick. But the disconnection between the low and the high roads can also be responsible for some psychopathologies. Once people become conditioned to be fearful, and this will happen when you have a kind of pain that is very episodic, like facial pain, like trigeminal neuralgia, where you have episodes of it. And those episodes train your brain to look for threat. And over time, that will cause a shift in the way you perceive the world, so that now you're seeing all sticks as snakes. Does that make sense? It's a shift toward a more vigilant orientation to the world. And you become different than your friends who don't suffer in this way. And you begin to feel different. You begin to feel like you're not like the others. And that's because you aren't. Some things have changed. So back to the brain. A synapse is a single connection between nerve cells. And these single connections between nerve cells in the aggregate form networks. And these networks are what give us identity. They are what give a, they are the foundation of learning. So somewhere in your brain, there is a network devoted to the way that you see yourself. Am I tall? Am I short? What do I do for a living? What kind of a dad am I? What kind of a mom am I? What kind of a friend am I? All of those things that you identify as features of yourself are coded in this wiring that we call a network. And this network is made up of synapses, each tiny little synapse connecting one to the other. And the saying that what fires together wires together is true. So there is a kind of a rehearsal or practice effect. Your brain is cobbled together as a function of experience. The way you see things, the things that happen to you, all those things drive the way in which your brain assembles itself, puts itself together. And the brain is a very dynamic organ, meaning that it's changing all the time as a function of your experience and the way you see the world. That's what we call learning. This is a functional magnetic resonance imaging, something called a diffusion tensor, and it takes a picture of the brain while it's working. So here you can see a brain where all these deep centers, thalamic structures, limbic structures, are connecting with the outside part of the brain in this bidirectional way. So thoughts or impulses go out, thoughts occur, and go back down and change the nature of your impulses. So this may seem very abstract right now, but it will come down to you in just a minute. So we talked a little bit about synaptic plasticity. This is the way the brain changes itself as it learns. Okay, so here's where it gets interesting. All of that abstract stuff becomes really, really interesting when you think about the source of fear or the source of threat being inside of you. So it's not like the stick on the bridge. It's a thing that happens inside of your body, and it can initiate or begin without you having any control over it. That's a very interesting psychological reality. And it's the reality in which some of you find yourselves, and it's particularly likely to cause psychological problems. So how do you live with this? How do you live in this emotional toxic field that's created by you having a fear stimulus, a snake, if you will, that lives inside of you and can bite you whenever it wants to? And you may not always be able to identify why it bit you, but your brain will look for a reason why. Was it the wind? Was it brushing my teeth? What was it that caused that thing to happen again that hurts me from inside of my body? And that is a very, very difficult position to find yourself in, as you all know. So I would like to just talk about one way in which this reality that you find yourself in as a facial pain patient can corrupt the experience that you're having. So we talk something about personal distance in the world of social psychology. It's that bubble that lives around us, and there are layers to the bubble. And these are things that we share as human beings, or we share culturally. These are cultural experiences, so they're different from culture to culture to culture. But when someone doesn't share this cultural experience, they stick out. People that stand too close when you meet them, or people that stand unusually far, these things register with us because we see those people as behaving differently, although we probably don't think about it in these analytical ways, but we do see it and we do recognize it without any training. It's built into the brain, is my point. So these are the bubble layers, okay? Intimate distance, 18 inches roughly, and this space is reserved for very special beings, family members, lovers, pets, and other people are not supposed to get into this space. Now, we'll talk about times when that happens, like the dentist, and how that can be a particularly threatening experience for everyone, but especially you. Personal distance, 1.5 to 4 feet, friends, acquaintances, a handshake, or we used to shake hands. That distance is kind of like close enough to hurt you, but not 18 inches close. And then social distance, 4 to 12 feet, and then public space, more than 12 feet. When you have trigeminal neuralgia, this intimate distance thing gets all messed up. I started to use an obscenity, but I restrain myself. But that intimate distance is corrupted. One of my friends who has trigeminal neuralgia talks about the fear that she had holding her grandchild who wanted naturally to reach up and touch her face, but the touching of the face was scary because it could initiate a trigeminal neuralgia shock, and it messed up that whole psychological experience of holding that new grandbaby that wanted to reach up and touch her face. And if you've got facial pain, you've experienced this corruption. And if you love someone that has facial pain, you've experienced this corruption as well, because you may not be as welcome into that 18-inch space as you would otherwise be if you weren't with someone who has facial pain. And I mean, obviously, the more you think about this, the more apparent it becomes that the experience of pain, and particularly facial pain, begins to corrupt your experience of self and relationship. So this may seem a little bit jarring to go back to the concept of anxiety, but they're all really related. What you should ask yourself, I think, today is, has this gone far enough? Has the difficulties that facial pain creates, has it gone far enough that now I have what would be legitimately diagnosed as an anxiety disorder? Is it time for me to go get some treatment? And let's look a little bit more closely at that. All anxiety disorders promote you or promote the individual to seek control. All of them push the individual to try and control their surroundings. It's an effort to keep themselves safe. And this always involves some effort to control other people, which other people resist. They push back against this, and it creates tension in relationships. Now, in the patients that I've seen who have facial pain, this very often shows up in things like, I really want to go visit my family and I want you to come. They invited us over for dinner. And they want you to come. But I'm afraid if I go, the patient says, I'm afraid if I go, I will have an attack of facial pain and I'll have to leave the room. So I think I'm not going to go. And there is the implicit pressure for the partner not to go. So if you go see your family for dinner and you leave me behind, you're abandoning me, and that hurts. And so these things get very, very complicated as people try to limit their exposure to threatening environments by controlling their environment. And that includes controlling the people that populate their environment. And this process of trying to control as much as possible inevitably becomes obsessive. And this involves thinking the same thoughts over and over and over again, something that we call ruminating. You might call it worrying. And what I'm hoping that you will do is see that when you do that, you're effectively wiring in that network of worry. You're wiring in that network of fear. And, synapse connects to synapse, synapse connects to synapse, connects to synapse, and you're building a bigger and bigger and bigger neural network devoted to fear. And the people in your life begin to take on significance only in the context of whether they are causing you fear or relieving your fear. So this fear network becomes cancerous, metastatic. It takes over your whole experience. And we call that an anxiety disorder. So back to high roads and low roads. So the low road experience is an instantaneous experience of terror, boom, and then escape, terror and escape. And if you can't flee, then you fight. But that's not anxiety, that's fear. Anxiety is a cognitive process. It involves thinking about and thinking about and thinking about, worrying and fretting and stewing. And that's what this is a picture of. So obsessive compulsive disorder, we've thought of that as a kind of anxiety disorder. It's got its own category now in the DSM-5, but it involves a prominent experience of anxiety. And what you see here is a positron emission tomography scan. So what's lit up here, the yellow and red areas of the brain are areas that are using glucose, they're metabolizing, they're active. And you can see in this obsessive compulsive brain that this front part is very, 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 very active, where in the normal control, it is not so active. Now I want you to remember the high road thing, okay? So this is a normal high road experience. This is a person having an experience, they're doing something, they're at a dinner party, they're at a seminar, and they're looking around and they're observing what's happening. And there's a portion of the brain, for sure, that's aware of danger or threatening experiences, but just a portion. In this other brain, it is lit on fire with the search for threat, with the search for potential harm. And this is the experience of anxiety. It is the high road working, but it's caught on fire. It's not normal any longer. So what normally happens in a high road experience, the individual is looking at what's going on and trying to figure out what needs to be fixed or changed or avoided. Okay, so that this threatening thing, whatever it is, does not happen again. Good, great. Figure it out, avoid it the next time, limit the exposure to whatever. Good, that's good. But what can happen is this kind of obsessive loop can form where people go over and over and over and over the same topic, looking for an answer that can't be found, that isn't out there. And that obsessive ruminative experience is typical of anxiety. And it will happen to people that have episodic pain, like facial pain. As you go over and over and over and over that last dinner party that you went to, looking for what caused that facial pain experience that you had that time. Now, what you've lost contact with is that 1 out of 10 dinner parties you experience facial pain. But they all feel dangerous now. So all of them are snakes, none of them are sticks. And your life begins to shrink as you get caught up in this obsessive, ruminative effort to try and figure out where the danger is in a context where the danger is inside. It's not something that you can avoid, unfortunately. And this becomes a very, very complicated thing. So let's talk a little bit about anxiety disorders generally. So for all people, not just people with facial pain, because what we will find out is that some of you are relatively immune to this process happening. It's not that you're indifferent to facial pain. Of course, nobody can be indifferent to trigeminal neuralgia. It's horrible pain. But some of you will catch on fire. Some of you, this whole thing, this high road thing will catch on fire. And those people probably have some genetic vulnerability. So if we look at anxiety disorders, anxiety disorders tend to have an early onset. So the late teens and the early 20s. Maybe it's not diagnosed, but that's when the problem started. The person started to feel tense or anxious. And it's common. 1 out of 5 people are genetically wired for anxiety. And you know, you're not alone in this. Lots of people have this problem. And for reasons that we do not understand, it's more common in women. People are looking at this. They've ruled out the hormonal thing. You know, they don't know why, but both anxiety and depression are 2 times more common in women. It has a waxing and waning course, meaning that it kind of goes up and down on its own. All right, kind of gets worse, and then maybe it'll get better, and then it gets worse again. Doesn't ever go completely away, but the intensity of it will wax and wane. The rule of thirds, simple concept. A third of people have hardly any difficulty with it. Yes, they have anxiety, but it's not that big of a deal. A middle third, yeah, it's a big deal some of the time, and they probably should get treated. And then the top, this other third, this last third, it's disabling. It's a really crippling problem. And you know, some people, I think this is getting better with time, don't think of these psychiatric or emotional problems as real diseases or disorders, but they are. And the research teaches us that they have just as much impact on our lives as diabetes or other chronic disorders. So let's look at the symptoms of anxiety. Has to have lasted a while, 6 months, okay? You worry too much, but you can't control it. And it's associated with physical symptoms too. You feel restless, keyed up, on edge, and this wears you out. So there's this paradoxical fatigue. You're tired all the time and on edge, which is a really miserable experience. It's difficult to collect your thoughts and concentrate when you're having this experience. You're irritable and snappy. Your muscles get tense all over your body, but in your face as well. So you will clench your teeth. And this is not good when you have facial pain, obviously. You can't sleep well, you have difficulty falling asleep, difficulty staying asleep, and this disturbance of sleep makes it more likely that you're going to have facial pain attacks. So another kind of anxiety disorder, let me just race through this because I think it's relevant. A specific fear. You're afraid of something. And the reason why I bring this up is because most of you develop some fear of the dentist. All right, I'm going to skip that. 10 to 20% of the adult population suffers with dental anxiety. Now, some of those people don't have facial pain, but for people who do have facial pain, going to the dentist can be a terrifying experience. I mean, really, really crippling in terms of the terror. Because you're afraid that the dentist is going to set all of this off. Well, unfortunately, I mean, that creates a scenario where you don't go soon enough, or you don't get regular sort of preventive dental care, and that makes it more likely that you're going to have problems that will land you in an endodontist office with something more extensive than just the typical cleaning. And all of that, of course, is conditioned by your experience with pain. And it's about all sticks looking like snakes. So now what? We could go there. I mean, if you have an option for nitrous in the dentist's office, I say take it. So psychotherapy, you don't want to be this worried monkey. You want to be the smiling monkey. And a good psychotherapist can help you be the smiling monkey. And when I talk about this with people, they inevitably ask, well, do they have to know something about facial pain? Do they have to know something about chronic pain? Yeah, it's great if they do. Yeah, for sure, it's better. But any good therapist should be able to treat anxiety competently. It's so common. If you're out there doing psychotherapy and you can't handle garden variety anxiety, you really should take your shingle down. So I think if you cannot find someone who specializes in chronic pain, maybe because you live in a rural area or you're not close to a university, then just a good, solid therapy relationship to address anxiety will be useful. It will be helpful. You may have to teach your therapist some things about your facial pain, but your therapist should be able to help you in your experience of anxiety without understanding anything about facial pain, because the dynamics of anxiety are the same. So those are all of the slides I brought. I raced through them so that we would have time to ask questions, because I think that's where we really get into the good stuff. So let me turn it over to you and see if there are questions.
Okay, I am back. Thank you. And I wish you could have heard me chuckling. Those were the last few slides were pretty funny. That monkey's got some good teeth. I'm impressed, actually. I think he's been to the dentist. So we have a couple of questions. I want to encourage everyone to type your question in the Q&A box. You can find that by moving your cursor down to the bottom of your screen and clicking where it says Q&A. So I have a couple of questions here. Is there a greater risk of developing anxiety if the person with facial pain is in their earlier years, is a teen, is in their early 20s? So is there a greater risk of developing this if your pain onset is when you're in those younger years?
If I understand the question, I'm not aware of any research, but I think the answer has to be yes. I understand facial pain because of its particular episodic nature. It's not like low back pain. Low back pain just sort of settles in. Yeah, sometimes it's bad and sometimes maybe it's not as bad, but it just sort of sits there. Where facial pain, you can be asymptomatic and then boom, you'll have this very, very, very significant experience of pain. I think of that like trauma. And we know with other kinds of trauma, combat trauma, any kind of trauma that you might think of, the more exposures you have to the traumatic stimulus, the more likely it is that you're going to have some sort of psychological effect. So if somebody starts off with facial pain in their 20s, I'm afraid the bad news is this has to make that person more likely to develop anxiety and other, depression as well, simply because of the prolonged experience of suffering in that way. Yeah.
Okay, and then a related question from one of our volunteers who works with families with kids who have facial pain. Should the parents be concerned about the siblings of the kids is there sort of trauma or related concerns about anxiety for the siblings of the kids who have facial
Oh my God, that's a great.
And there's an episode and your kid is on the floor or screaming in pain. That's got to cause trauma and issues with the other kids, no?
Yes, that's a great question. So let me tell you about a monkey study. Two groups of monkeys, a light comes on and a shock is delivered. So the light is the signal, shock is coming. One group of monkeys is trained to press a button when they see the light and turn off the shock. The other group of monkeys just watches, okay? And those monkeys that are just watching the experience of their fellow monkey getting shocked, when they look at their stomachs, those watching monkeys, observing monkeys, have more erosion in the stomach lining than the monkeys who actually had control over the scenario. And that goes directly to this question. So the sibling who's watching this is like the monkey watching the other monkey get shocked. They have no control. They're observing a fellow human being and a loved one suffering without any capacity to impact that suffering. And we know that that is actually a psychologically very dangerous place to be. So, I mean, it's I don't know, sort of nihilistic or maybe scary. But if you're one of those people that has a child with facial pain who has a sibling, the sibling should probably go into psychotherapy as well. They should both be receiving some sort of support.
Okay, thank you. We did get a question before you even talked about the dentist, so it was a very relevant question here. How would you recommend that someone who is in fear going to the dentist, how would you recommend, it's more of a practical question, them verbalizing what's going on with them? I mean, that's embarrassing. You're at the dentist, you're in public, you're having this episode of anxiety and fear, can bring you to tears. How would you recommend someone actually can verbalize that or bring themselves to verbalize that?
Verbalize it is, I don't know a dentist, and I know lots of them, but I don't know a single one that does not understand that trigeminal neuralgia is a really awful experience. So they're not naive. They may not think about it with every patient because trigeminal neuralgia is rare, right? But if you draw their attention to it, they will snap to, because they recognize that this is a very vicious kind of pain. And I would say, don't go into the relationship and say, I'm afraid. I know that you're a great dentist, so if you feel some need to take care of them, go ahead and do that. But I'm afraid that this is going to cause my trigeminal neuralgia to activate or to start, and can we have some kind of an arrangement where I let you know instantly if I'm feeling something happen? And will you be okay with that? Will you be patient with me? And if it's okay to ask, it's okay to ask, will you be patient with me? And if the dentist resists, so this is relevant. So when I talked about the low road thing, so I'm back to my roads. There is this structure in the brain called the amygdala. Amygdala is Greek for almond, or it's a Greek word meaning almond shaped. And so these two amygdalas sit on both sides of the brain, and they're where this low road experience starts. Okay? The amygdala do one thing really well in terms of analyzing. They have one gift, and that is reading facial expression. Because as a species, we have learned that one source of great danger is in our fellow human being. And so we've developed the capacity to read minute expressions on people's faces to tell us whether we're in jeopardy or not. And if you are reading your dentist's face and your amygdala is telling you that it's not safe, I would suggest to you that maybe that's the wrong dentist for you. Maybe you need a different kind of person, or a different kind of relationship with your dentist than the one that you might be having in that moment. So I don't trust yourself is what I'm saying.
Yeah, trust your gut, right?
Trust your gut, right? Yeah. When people say trust your gut, they're talking about that low road experience. Yep.
Great. Okay, so we had a question about the distance that you were talking about.
Right.
And the question is, does intimate distance only refer to physical distance, or does pain also cause change in intimate distance?
I'm not sure I understand the question, but let me respond to what I think I hear. That distance thing is physical. It is literal. How far can someone get, how close can someone get to you before your amygdala is going, snake, not stick, snake, not stick, you know, and that 18 inches is a sacred space. So it's a very, very physical thing. And pain obviously corrupts that experience. So if you didn't have facial pain in particular, if you did not have facial pain, then you would probably enjoy, like the rest of your fellow Americans, relative ease for certain people moving into that 18 inches. But if you have facial pain, you may be, your amygdala may fire when your sweetheart moves in to give you a kiss, or when your child reaches up to touch your face. So that whole built-in wiring that we have around that intimate distance gets corrupted, it gets fouled up, it gets messed up by the experience of pain.
Okay. We have a question. This is one of the topics that you and I talked about possibly for a future, but I'll ask the question. I don't know if you can give a short answer, but if the need for drugs arise, and I'm assuming we're talking about drugs for I don't know what you call drugs for. I don't think we're talking about drugs for facial pain. We're talking about drugs for anxiety. What drugs are good to use is the question. So
great.
I want to answer that.
That's a great question. And you asked for a short answer. I don't know if I can give you a short answer.
That's okay. Give me a medium answer.
We're back to this picture. Can you see the picture still?
Yes.
All right, great. So this hot area of the brain is a serotonin heavy part of the brain. So the chemical that makes that part of the brain work is serotonin. And disruption or imbalance in serotonin levels are typical of brains on fire, okay? Now we can give somebody a serotonin reuptake inhibitor, and it will take this hot brain, this on fire brain, and it will make it look like that normal brain. It will pharmaceutically adjust the neurotransmission using a drug that controls serotonin levels. But here's the fascinating thing to me. When we take people and we put them in highly specialized treatment for anxiety, cognitive behavioral therapy or desensitization therapy, and we look at their brains with positron emission tomography, we see the same change, that the medicine causes. So if I take a patient and I take a picture of their brain before cognitive behavioral therapy, it might look like this. It might be on fire. And then I put them through good cognitive behavioral therapy treatment and I look at their brain again and it looks like this. So medications can do this and psychotherapy can do this. And obviously the best thing is both.
And so you gave sort of the kind of medicine. Are there names that you'd feel comfortable saying so that someone can go write it down and go and ask their doctor specifically about certain drugs?
Sure, I'll give names, but understand that not every drug is okay for every person, right? So
Yes, absolutely.
common serotonin reuptake inhibitor drugs would include things like sertraline, Zoloft, Celexa, citalopram, Lexapro, escitalopram. Those are the three biggies. An old-fashioned one, Prozac, fluoxetine. Those are all selective serotonin reuptake inhibitors. Of those drugs, Lexapro is the one that's the most elegant, the most highly specialized. The other, when I say the most elegant, what I mean is it tends to have fewer side effects because it's just touching that serotonin synapse. It's not touching any of the other stuff. It's very, very specific, it's highly specific. So those drugs are all excellent for anxiety.
Okay. All right. Wonderful. So people can ask their doctors about those, if those would be right for them. And if, when we do the survey at the end, if people say that this is something they want to learn more about, we can maybe do some further education about what might be good options.
I feel like I have to add something though.
Please.
All of those drugs cause clenching as a side effect. And that,
You're talking about like this? You mean
grinding your teeth, all of them.
really?
And so if you use one of those medicines, and I'm all for it, go for it, yes. Go to your dentist and get an oral appliance made because it will protect your teeth and it will also limit the effect on the facial musculature and make it less likely to stir up your trigeminal neuralgia.
Okay. I have a lot of questions about why that would be because it seems sort of counterintuitive when you're talking about something that's going to decrease your anxiety, but it causes this clenching, which feels like this is exactly what anxiety would do. So, but
you want to answer to that or no?
No, let's move. We're going to move on because we have some other really good questions, but I'm curious. So, okay. How do you know the difference between wisely avoiding triggering situations or things versus fearfully obsessing and ruminating about potential pain?
Oh, if only I could answer that in a simple way. If it's beginning to affect your quality of life, this is really an interesting question the more I think about it. If it's beginning to affect your quality of life, if other people are telling you, or you're getting the feeling from the way that they interact with you, that you're over the top, or that your worries are perhaps overblown, it's time to stop and think about it. Now, maybe that other person is being insensitive. Maybe they're not really understanding your experience, but maybe they are. And in any case, it's a trigger, or it should be a trigger for you to stop and reflect and ask yourself if you've changed. Have you changed? Has your capacity to enjoy stuff become limited where before you could? So you're looking for changes and you're looking for quality of life. I don't know if that answers the question, but I think that's the best I can do.
Okay, wonderful. This next one is maybe another complicated one. Can childhood trauma, and I will add any kind of past trauma, play a part in how you perceive and cope with facial pain?
Oh, yes. So let's say that as a child, you were exposed to sexual abuse. That in terms of, and oh, it's tragic actually. At a time when your brain is wiring itself together, it is making itself, all right? So we know that the brain is wiring itself together and creating a kind of a relatively durable sense of self up to about age 14. And so, or some people say as long as 25, but for sure for the first 14 years. And let's say during those years you're being sexually molested or you're being physically abused. What's happening is that neural net for the low road is getting expanded, it's getting built. And so it becomes much bigger, much more, it takes up much more real estate in the brain. Now, and so you're going to be the kind of person who doesn't trust easily, who finds it difficult to relax. And it's because this hypervigilance or this fearful part of yourself has become so large and dominant in your brain. Now, we add to that the experience of facial pain, and it's going to light that circuitry on fire. That circuitry is already there. It's already dominant. It's already expansive in the brain. It's just sitting there waiting to fire. And now we give it pain. Of course, it's going to make it, yes, it's going to make it a much more difficult experience.
Question, yeah, go ahead.
So far, I mean, if that's true for anyone out there, don't wait. Go see a therapist. It's just not even you must go see a therapist.
This next one, we hear this a lot in the office, and I know our volunteers get these kinds of questions. A lot of times people who are in remission are just always sort of on the lookout or have fear, anxiety about pain returning. So what advice would you offer someone who's in remission, or I will add, maybe had a treatment and their pain is lowered or gone, and the fear and the anxiety about pain coming back.
What I'm going to suggest is going to feel and sound extremely artificial. But what I'm going to suggest is force and simplistic. Force yourself to stop thinking about your experience of pain. Now, it's like, don't think about a pink elephant. Well, yeah, okay, so now you're thinking about pink elephants. So it doesn't work to tell yourself, don't think about that. It works to get yourself involved in new things, learning, pick up the piano, go to one of those things where everybody sits in a row and paints the picture. Do something with your brain. Occupy your brain. Do something with your brain so that you don't leave it idle to think about pain. And if you do that, if you take away those thoughts by occupying your brain with something else, that neural network will shrink and other functions will expand. So let's say you pick up the piano and you're learning, to play scales, or you're learning to play your favorite song. That will occupy more neural net, and that neural net that was devoted to the experience of pain will start to shrink. It's a simple, don't feed the wolf. Don't feed the wolf.
Feed the good wolf. Isn't there that story, Feed the Good Wolf?
Right.
Yeah. That's a good segue to our friend Anne's question about what happens in psychotherapy. I'm kind of guessing that you're doing a little bit of maybe what you might do with a patient. What would a therapist and what would the patient do? Someone with facial pain goes for psychotherapy.
Okay, so somebody comes to me for psychotherapy. The first thing I'm going to do is just get to know them. Is there any history of psych trauma? That I'm going to do a good background search. I'm going to look for stuff. But then all that's done and we kind of know each other. The next thing I'm going to do is teach them how to relax. We're going to go over a really sound relaxation paradigm. We're going to breathe together. We're going to do some soft, sweet imagery together, and we're going to use that as a basic tool bag. Now we're going to talk about the things that are threatening. Once that little tool bag of relaxation stuff is really learned well, then we're going to start to introduce talking about the things that are scary. And as we talk about them and as the distress starts to build, we're going to stop the discussion. Okay, we're going to have a system worked out. You're going to raise your finger, or we're going to have some kind of communication. You're going to say, I'm getting uncomfortable. Okay, good. Now we're going to do the relaxation thing. So it's artificial. It's very, very mechanical almost. So then we're going to stop the conversation and we're going to do the relaxation thing. And little by little, we will start to erase the board by superimposing this relaxation experience over these traumatic stimuli. It's a process called desensitization.
What you talked about the fear, the anxiety about the periodic pain, the episodes of pain. Someone has a question about, he has constant pain. So what is the difference of the effect on the brain of someone with constant pain versus the triggers? Maybe is it less anxiety, more something else, or?
I think probably you're more likely to experience depression as opposed to anxiety, because the thing that's provoking the anxiety is the combination of it being episodic and unpredictable. So constant pain is predictable. And that sets people up more for a depressive picture as opposed to an anxious picture. And, you know, I would also say, and this really opens sort of a can of worms that in therapy, much discussion goes on about. But when people say that they're in constant pain, within that constant experience of pain, there are moments of relative intensity and relative low intensity. So one of the things that you need to do with someone who reports constant pain is to help them learn to identify periods of relatively low pain, because it's all become the same to them. And learning to discriminate between periods of high pain and low pain is a very essential part of psychotherapy.
Okay. A couple more questions. This person is talking about how she has developed a phobia towards wind and stays indoors most of the time. During COVID, she has been wearing face masks, which has helped, but now she's feeling anxious about not wearing masks anymore, and now the wind is going to affect her face. This to me also kind of jives with a lot of what we hear, that a lot, you know, people staying home and isolating because of COVID, and now everyone else is getting back to being out, and this fear of having to return to being social and going out. So I'm not sure that's the same question, but I guess first address, please, what you would recommend for someone who has really developed a phobia towards a trigger that is really now affecting them living their lives.
Well, I think there are two things. All of America is sensitized now to social contact because we've all lived in our little caves. And as we were coming out of our caves and we're back into the social field, we're all having that amygdala fire. Okay, so it's a universal experience. But with a person with facial pain in the wind, this is commonly reported in my facial pain patients. They're very much afraid of the wind touching their face. And what I would say is, not every day is a windy day. Some days are highly threatening that way, and other days are relatively low in threat. There's the air is still, there's not as much wind. And you would say to me, understandably, you would say to me, yes, but even on a still day, I might go out and there might be a breeze and it might touch my face. But what I would say to you is, it's about ascertaining risk. And when the risk is low, it's important to move toward the experience when the risk is low. Because otherwise, if all risk is appreciated at a high level without any discrimination between high risk and low risk, you will have no life. You will have no life. So it's important to be able to appreciate relative risk when that is possible to do.
Okay. And then one more question. I got a few questions actually about PTSD. And I was trying to sort of think about exactly how to ask this. I'm going to go with kind of how Megan framed it. Is there similar effects on the brain on these two groups?
Yes, there is. So interestingly, with the current DSM-5 diagnostic system, facial pain would not qualify as a criterion A stressor, but that's not the question that they're asking, okay? If we look at the brain, of course, there's enormous similarity because of the unique nature of facial pain. It's not like back pain. It's jabbing, jarring, shocking, zapping pain. Trigeminal neuralgia type 1 is. And that is a very much an insult or an assault that is not unlike trauma at all. I mean, it's very similar. So the setup is, I think, very similar to PTSD.
Okay, wonderful. All right, I am going to try to launch this poll. I don't know what's going to happen. I might press the button and we might all disappear, but I'm going to try to do this just to see. So the question is here, what topic would you like Dr. Scott-Morrow to cover next? Depression, types of psychoanalysis and medication, how facial pain affects relationships. I can add something else, Dr. Scott-Morrow, if you think I can pop another one in there real quick.
And I think this is an interesting thing, approaching facial pain using the treatment of facial pain using a PTSD treatment paradigm. I mean, that's a wordy thing, but treating facial pain as you would treat PTSD. Maybe people would want to know more about that.
Okay, I have to retype this one.
The traumatic aspects of facial pain.
Traumatic aspects, I'm sorry, I have to type this really quick. Facial pain. This is what happens when we have a live broadcast. Okay. We talked about psychoanalysis and medication. I know we talked about depression.
The effects of childhood trauma.
Okay, all right. And I'm going to send that out and let's see if I can do this. All right, I'm going to give this a try. Okay, all right. Can you vote for several? I think you can vote for several. Someone's asking if you can vote for several. Let's see what happens.
Like they did in New York. Never mind. Voting. Never mind.
All right.
Sorry.
Let's see. All right. Wow, this is very cool. For those of you who've done this before, you're thinking, I have no life if I think this is something I find fun. But this is very cool. We're getting our responses. Mm-hmm. I mean, we're getting a PTSD option did not show up. I'm sorry.
That's okay.
Let's see. 54% are saying how facial pain affects relationship. Mm-hmm. 30, the numbers are still wiggling around a little bit. Definitely getting people saying PTSD. And then the second is depression. And then the third, types of psychoanalysis and medication. So I really think we probably couldn't go wrong. I think we can maybe figure out how to, but certainly the relationships and depression are the top two.
I think those can be handled in the same presentation.
Wonderful.
Yeah.
Okay. Thank you, everybody, for voting. That was pretty cool. I appreciate everyone for coming. Dr. Leesa Scott-Morrow, thank you so much for your time. You know, people are texting me and messaging as you're talking, and you're really doing so much good for so many people who are affected by facial pain and their families too. We got some questions about parents and about children and siblings. Thank you for an excellent presentation, somebody just said. So thank you so much. We really appreciate it. And we're thrilled that you're going to come back and give us some more. So
pleased to do it. Yes.
Thank you, everybody. Have a good night.
All right. Bye-bye.